we run into the first major hurdle for anyone trying to study this material.
Oh yes, the timing.
The confusing dual timeline system used to date a pregnancy. It seems like we know that the concept of age in utero uses two different clocks that are consistently about 2 weeks apart. Let's dive deep into why this time confusion exists and why it's a necessary evil.
It truly is a functional necessity. It's all about balancing clinical practicality with biological accuracy.
Okay, so what's the practical side, the clinical one?
Clinicians worldwide primarily use what's called gestational age, or GA. You'll also see it called postmenstrual age, or PMA.
And that's calculated from what?
It's calculated from the first day of the last normal menstrual period, the LMP.
That makes sense from a medical perspective because for decades that was the most reliably known starting date for any pregnancy.
Exactly. It's the standard historical benchmark. It's something a patient can usually recall with some certainty.
So using that clinical standard, how long is a pregnancy?
An average full-term pregnancy is defined as 280 days.
The 40 weeks everyone talks about.
Precisely 40 weeks PMA. However, biologically, the actual moment of conception, the fusion of sperm and egg, that occurs roughly 2 weeks after the LMP.
Right, around ovulation.
Yes. So the true biological age of the embryo or fetus, what we call the post-fertilization age, is actually about 2 weeks shorter.
So around 266 days.
Approximately 266 days, or 38 weeks, for a full term.
So we have this mandatory 2-week lag. The fetus is always 2 weeks younger than the pregnancy is clinically dated. What are the clinical and research consequences if we don't properly account for that 2-week discrepancy?
The consequences are profound, especially in research where the timing of, say, a drug exposure or environmental insult is being studied.
You could be off by a huge margin, developmentally speaking.
A massive margin.
Wow.
Imagine trying to compare two studies. One uses post-fertilization age to describe when the neural tube closes, and the other uses gestational age. If you miss that translation step, you misattribute a biological event by 2 full weeks.
Which, in the rapid fire of early development, is basically a lifetime.
It is. This is why standardized developmental tables, like the one in Figure 23.3 in our sources, are the foundational translator. They're essential tools for everyone from embryologists to obstetricians.
They force you to correlate the two timelines.
They mandate the correlation. For example, if a paper notes that a key event happens during LMP week 12, we have to internally translate that to mean the embryo is only at post-fertilization week 10.
And without that 2-week adjustment.
You can't compare findings, you can't estimate viability accurately, you can't even define prematurity correctly. It's the gatekeeper to understanding all the subsequent measurements of size and development.
I appreciate the clarification. It sounds less like confusion and more like a mandatory translation step in the scientific language of human development.
That's a perfect way to put it.
Now that we know which clock to use, let's zoom in on the most detailed and precise measurement system of all. How we define the early architecture of the human body before it's even big enough to see on an ultrasound.
The embryonic period.
Okay, let's unpack those earliest stages, the first 8 weeks post-fertilization, which define that period. Before size can be reliably measured, how do researchers standardize and grade the development of this tiny structure? What anchors their comparisons across different specimens and even different species?
We use a system of exquisite detail and historical precedence, the Carnegie staging system.
Okay, Carnegie staging.
This system, initially developed way back in the 1940s and then rigorously updated by O'Rahilly and Willer, does something brilliant. It doesn't rely on chronological age or size, which are, highly variable.
So what does it rely on?
It shifts the focus entirely to morphological milestones.
So it's a form-based system prioritizing structural progress over the calendar. I can see why that's more reliable, but if size is irrelevant, how is it even structured?
It's structured into 23 distinct stages, which cover the first 56 days post-fertilization.
So day by day for almost 2 months.
Roughly. And a specific Carnegie stage is assigned only when a defined set of external and internal morphological features are present or have just formed. It's about events, not time.
Can you give me an example?
Sure. Stage 10 is defined by the first appearance of somites, these little blocks of tissue. It doesn't matter if that happens exactly on day 28 or day 29. The appearance of the structure is what defines the stage.
And that's a much more accurate gauge of developmental progress than just measuring its length.
Far more accurate. Measuring something like crown rump length only really becomes a reliable proxy for age later on.
That distinction morphology over mere dimension is critical for research reproducibility. So let's walk through the architectural blueprint, focusing on stages 6 through 18, where the body's fundamental plan is really locked in.
Absolutely. We begin with the absolute foundation, the creation of the germ layers. This is stage 6, which happens around day 13 post-fertilization.
Day 13, so before a pregnancy is even typically confirmed.
Oh, yes. And this stage establishes the polarity of the future organism. Key features include the initial reflection of the amnion and the clear differentiation between the epiblast and hypoblast layers.
And what's the most important feature of stage 6?
Most crucially, this is when the primitive streak forms.
The primitive streak. I heard this is a massive biological decision point. It's not just forming, it's directing the entire future architecture.
Precisely. It's a temporary structure, but it's the absolute foundation line. It defines the long axis of the embryo, and it kicks off the process of gastrulation.
Which is?
Gastrulation is the process of creating the 3 definitive germ layers, the ectoderm, mesoderm, and endoderm, from which every single organ in the body will eventually derive.
So if that process is disrupted, the consequences are
Catastrophic. It's a fundamental step. Moving on from there, we enter a period of just intense structural differentiation.
we're jumping ahead to stage 10, around day 28 post-fertilization.
Yes, and just 2 weeks later, the embryo is unrecognizable. This stage marks the beginning of neurulation.
The start of the nervous system.
Right. The neural plate begins to fold to form the neural tube, the basis of the entire central nervous system. At the same time, we see the appearance of the first pair of somites.
Those tissue blocks you mentioned.
Yes, these blocks of mesoderm that will segment and go on to form the vertebrae, the skeletal muscles, and the dermis of the skin.
And what else is happening at stage 10?
Concurrently, the first architecture of the heart, the pericardial heart development, begins. You can often see it as a pulsating bulge that has already initiated a primitive form of circulation.
Wait, the heart is beginning to beat at only 4 weeks post-conception, while the neural tube is still closing. That functional requirement of the cardiovascular system overlapping with the structural creation of the nervous system is staggering.
It highlights the extreme prioritization of the transport system. The embryo gets too big for simple diffusion very, very quickly. It needs a pump.
And the structural organization just keeps going.
Aggressively. Next is stage 13, around day 32. This stage is really focused on the head and the emergence of appendages.
What are we seeing here?
We see the formation of the first pharyngeal arch, which is a massive milestone because these arches contribute heavily to the face, neck, and throat structures, including blood vessels and nerves.
So the very foundation of the face.
The face, the jaw, the ears, the sensory organs are also beginning their formation, with the optic vesicle appearing. That's the future eye structure.
And the limbs.
Finally, the first visible sign of the limbs. The upper limb bud appears as a small paddle.
So barely 5 weeks in, and we have the blueprint for the face, the heart, the spine, the brain, and the arms. It really emphasizes the speed of this critical window of development.
And this pace doesn't slow down. The remaining stages are all about refining these structures.
So on to stage 16. That's around day 37.
Yes, and now the facial structures become much clearer. The maxillary and mandibular processes are distinct. These will form the upper and lower jaws.
And the lower limbs catch up.
The lower limb bud is now visible, following the upper limb bud in its formation, which is a consistent pattern. And inside the head, the central hemisphere of the brain is becoming prominent, beginning its rapid period of expansion.
And then just a week later, at stage 18, around day 44.
By now, the form is rapidly maturing toward, what we'd recognize as human. The eyelids are beginning to form, differentiating from the surrounding facial tissue.
And the ears.
The pinot, which is the external ear structure, is visible. And critically, the hand is no longer just a paddle.
It differentiated.
It is clearly differentiated, and you can see the fingers, though they're still webbed, are beginning to separate.
So by day 56, or stage 23, the embryo is essentially structurally complete, and it transitions into becoming a fetus.
Yeah.
The use of the Carnegie system provides that shared, standardized language for comparison. But beyond research, how does this standardization benefit clinicians?
It allows for immediate pattern recognition. If a clinician sees a structural anomaly on an early scan, they can pinpoint exactly when the disruption must have occurred.
So if a major heart septum is missing,
They know the insult must have happened around stage 10 to 13. This system allows for accurate comparison not just between different human cases, but it's also foundational for translating findings from animal models into human applicability.
which is essential for studying toxicology, genetics, All of it.
All of developmental biology worldwide. It removes the subjectivity of relying solely on the calendar or a tape measure during this incredibly volatile phase.
The pace of those Carnegie stages underscores that weeks 3 through 8 post-fertilization are an all-out sprint of biological construction. It's not sequential, it's concurrent.
It really is.
If you look at the general timetable of development in Figure 23.2, it looks less like a linear process and more like a chaotic traffic jam, where every major system is establishing its foundation simultaneously. How do we synthesize that complexity and visualize the immense risk this critical window represents?
That's the key word, risk.
Yeah.
We have to understand that this period, which coincides with the rapid changes of the Carnegie stages, is the window of maximum vulnerability.
Why then specifically?
Because the major systems are forming their structural foundations. Any interference, a maternal infection, alcohol exposure, a certain drug, is most likely to result in a major congenital anomaly, a structural defect.
And after week 8?
After week 8, the risk shifts. It's less about major structural defects and more about functional defects or growth restrictions.
So let's track the systems that have the most urgent start times and see how their timelines interlock. Which system absolutely wins the race to differentiation?
As we touched on earlier, the nervous system gets the definitive fastest start. It begins its formation even before the maternal period is missed.
That early.
By week 3 post-fertilization, we see the genesis of the neural crest cells. These are incredible, multipotent cells that migrate extensively to form structures all over the body.
Like what?
The peripheral nervous system, pigment cells in the skin, and even parts of the skull and facial skeleton. And at the same time, the first rudimentary neural canals are forming.
And just 2 weeks later.
By week 5, the sensory apparatus is in full development. The optic cup is defined, setting the stage for vision, and the otic vesicle, which is the precursor to the inner ear, is sealed off.
And by the end of this embryonic period, at week 8.
By week 8, we see sophisticated endocrine and cerebral development. The posterior lobe of the pituitary is established, which will regulate future hormone release. And the first major divisions of the cerebrum, the centers of higher thought, are underway. The sheer pace of neurogenesis is just unmatched.
And the body cannot sustain that nervous system growth without an immediate functional transport system. So the cardiovascular system must be established right alongside it.
It has to be. The embryo quickly grows too large for simple diffusion to sustain it. It needs plumbing and a pump immediately.
When does that process start?
Around day 20 post-fertilization, the primitive heart tube is forming, and by day 21 or 22, it begins beating. Structurally, the septum primum begins the critical partitioning that divides the single primitive atrium into left and right sides.
That's the start of the four-chambered heart.
It is. And by day 30, the septum secundum is forming, continuing that partitioning process. This delicate formation is why many common congenital heart defects are traced back to a failure of these early septa to properly fuse.
So the stakes are incredibly high in just those few days.
Incredibly high. And by day 50, and this is where a confusing term from our source comes in, the framework for the cardiopulmonology part of the skull is being completed.
Okay, that sounds strange. What does that actually mean?
It's a bit of jargon. It refers to the complex structures that arose from that early pharyngeal arch system we mentioned. This includes the major arteries, like the aortic arch, that connect the heart to the pulmonary and systemic circulation.
Ah, so it's about the great vessels and their relationship to the head and neck.
Exactly. The structural relationship between those great vessels and the formation of the skull base and neck is intimately linked in this early process.
Thank you for clarifying that. So the early cardiovascular development is a complex partitioning process, ensuring clean separation of pulmonary and systemic blood flows, even though the pulmonary system won't be fully active until birth.
Precisely. Now let's turn to the internal factories, the gastrointestinal and respiratory systems.
And I understand they emerge from the same foundational tissue, the primitive gut tube, right around week 4.
That's right. Around week 4 post-fertilization, we see the definitive differentiation of the three segments, the foregut, midgut, and hindgut. And simultaneously, the lung buds appear as a ventral outgrowth of the foregut, marking the start of the respiratory tree.
And then by week 6.
By week 6, the systems show major morphological changes. The respiratory system has formed its primary bronchi, starting the structural division of the lungs, and the GI system undergoes a critical, complex physical motion.
What's that?
The rotation of the stomach into its final adult position. This rotation is essential. It prevents future anomalies and allows the proper placement of all the other abdominal viscera.
And there's something else happening with the gut around then, right? It actually leaves the body temporarily.
It does. Around week 6 to 7, the midgut rapidly elongates and herniates out into the umbilical cord. There just isn't enough space for it to grow inside the small abdominal cavity. It grows out there, rotates, and then retracts back in later in gestation. Another process that has to be timed perfectly.
It sounds like the abdomen is essentially remodeling itself while the head is getting its eyes and ears. Finally, the urinary and reproductive systems. These are often referred to as the urogenital system because of their close developmental proximity.
They share several precursor duct systems. The structures appear around weeks 5 and 6.
What are we seeing then?
We see the development of the mesonephros, which is a transitional sort of functional kidney structure that precedes the final kidney, the metanephros.
And the reproductive parts.
Crucially, the duct systems for reproduction develop. You have the Müllerian ducts, which are the female precursor, and the Wolffian ducts, the male precursor. Both are present initially.
So at this stage, the gonad is
Indifferent. It has the potential to become an ovary or a testis, depending on the genetic signals it receives later.
and you can't tell externally at this point.
No. While these internal structures are present, external sexual differentiation only becomes macroscopically apparent after Carnegie stage 18 around week 8 as the embryo transitions into the fetal period.
So by week 8 post-fertilization, every major system is structurally initiated. The blueprint is complete. This means that when we talk about growth from week 9 onwards, we're almost entirely talking about increasing the size and functional maturity of pre-existing structures rather than forming new ones.
Exactly. It's an incredible conclusion. The entire functional and structural foundation of a human being is laid down in less than 60 days.
Once the embryo transitions into the fetus post-week 8, the architecture is set, and the focus shifts entirely to growth and refinement. We move from defining stages based on morphology to tracking dimensions with technology.
Right, and ultrasound becomes the primary tool.
So let's talk about how doctors use routine ultrasound scans to monitor this process, track growth, and critically assess risk.
The first goal of any scan is really to confirm viability and check for multiple pregnancies. But its most important use is establishing and refining the delivery date, which dictates all future clinical management.
Let's start with the first trimester ultrasound, typically performed between 7 and 12 postmenstrual weeks. What single measurement is the gold standard for dating here?
That would be the crown rump length, or CRL.
Crown rump length.
It is measured from the top of the fetal skull, the crown, to the lowest point of the buttocks, the rump. The period from about 28 to 84 days post-fertilization is when CRL is the most accurate predictor of age, often to within plus or minus 3 to 5 days.
Why is CRL so accurate in the first trimester, but loses its reliability later?
It's because in the first trimester, the fetus is highly constrained developmentally. The growth velocity is nearly uniform across all normal embryos. There's very little variation yet.
And later on.
By the second trimester, genetic variations, sex differences, and environmental factors like placental function start to influence length and weight. The variance just increases. Also, the fetus starts to flex and extend, so getting a straight measurement becomes physically unreliable.
Beyond dating, the first trimester scan also includes a key structural screening tool.
Yes, the nuchal translucency, or NT measurement. This is done between 11 and 14 postmenstrual weeks.
And what exactly is that?
The NT is the maximum thickness of the subcutaneous fluid space at the back of the fetal neck. An increased NT measurement is a screening marker, often combined with maternal blood tests, to assess the risk of chromosomal abnormalities.
Particularly trisomy 21.
Yes, Down syndrome especially. It's not diagnostic, but it provides essential information early enough for comprehensive diagnostic follow-up, like a CVS or amniocentesis if needed.
Okay, so as the fetus gets larger and the CRL is no longer reliable, we move to the second trimester ultrasound. This is the routine anatomical scan done around 18 to 20 postmenstrual weeks. This scan must be much more detailed, checking the execution of that architectural blueprint laid down in the first 8 weeks.
Exactly. The 18 to 20 week scan has two major aims: a comprehensive anatomical survey to check for structural anomalies, and biometry, using a suite of measurements to estimate fetal weight and adjust the delivery date estimate.
Let's detail those groups. Critical biometric measurements used to calculate the estimated fetal weight, or EFW. Figure 23.8 in the sources highlights the 4 core parameters.
These 4 measurements, when you combine them in various mathematical algorithms, give us the best overall picture of size and proportionality.
What's the first one?
The first is the biparietal diameter, or BPD. This is the largest transverse diameter of the fetal head, measured across the 2 parietal bones. It's useful, but sometimes the fetal position can artificially flatten the head, which can throw off the measurement a bit.
So there's a better head measurement.
The head circumference, or HC, is often considered more robust. It's measured in the same transverse plane as the BPD, but because it's a circumference, it's less susceptible to variations in head shape, what we call molding. It's a critical proxy for brain growth.
Okay, so that's 2. What's number 3?
Number 3 is the abdominal circumference, or AC. This is measured in a transverse view of the abdomen, and the technician has to be very specific to get the image plane to include the fetal stomach and the cord insertion point. This is the crucial measurement for a real-time assessment of fetal health.
And the AC is the most variable of the 4, correct?
It is, by far.
Yeah.
Because it directly reflects the status of the fetal liver, which is the primary site for fat and glycogen storage.
So if the fetus is well-nourished?
The AC is large. If the fetus is undergoing nutrient restriction due to placental issues, the liver shrinks as those stores are mobilized, and the AC measurement is the first to drop dramatically. It's the nutritional canary in the coal mine.
Fascinating. And the last one?
The fourth is femur length, or FL. It's measured longitudinally along the longest ossified part of the thigh bone. It's a reliable indicator of skeletal growth and helps us estimate the overall fetal length.
The sources emphasize that this 18-20-week scan is a checklist. What specific anatomical structures, besides those 4 biometric measurements, must be visualized and confirmed as normal?
The list is comprehensive, and it focuses on the high-risk systems established during embryogenesis. So for the central nervous system, they examine the transcerebellar plane to assess the cerebellum and make sure the midline structures and ventricles of the brain are intact.
Looking for things like hydrocephalus.
Exactly. Then the heart views are paramount. Given how often septal defects can occur, this is critical. The 4-chamber view confirms the presence and orientation of all 4 chambers, and the 3-vessel view ensures the proper arrangement and size of the pulmonary artery, the aorta, and the vena cava.
And these views can rule out most major heart defects.
The vast majority of major congenital heart defects, yes. They also check the aortic arch view to confirm that structure correctly. And finally, they meticulously trace the entire longitudinal spine to exclude defects like spina bifida.
And they confirm the other organs are there.
Yes, they confirm the presence of the kidneys, the bladder, and check the integrity of the abdominal wall by looking at the cord insertion to rule out things like omphalocele or gastroschisis.
That sounds like a long, high-stakes examination, ensuring that every piece of the architecture is sound. But sometimes ultrasound isn't enough to provide the necessary detail, especially concerning soft tissues. That's where magnetic resonance imaging, or MRI, comes in.
MRI is a powerful adjunct, but it remains a secondary, non-routine tool. It's used specifically when ultrasound findings are inconclusive or suggest a high-detail structural defect, typically after 20 weeks gestation.
And what's its main advantage?
Detail. Advances in ultrafast MRI allow for detailed, high-resolution, soft tissue images to be captured. This is invaluable for diagnosing suspected central nervous system abnormalities. For instance, detailing the severity of spina bifida or assessing subtle cortical development issues that ultrasound might miss.
So it gives the definitive diagnostic picture.
It does. It provides the information needed for complex prenatal management, or even, in some cases, preparation for fetal surgery.
So we have the gold standard measurements, BPD, HC, AC, and FL. The challenge now shifts from getting the measurement to interpreting it. What does normal actually look like in utero, and how do clinicians use statistical modeling to predict health outcomes?
This is where we transition from anatomy to statistics, using statistical norms or growth curves plotted against postmenstrual age. These charts show percentiles, typically the 3rd, 10th, 50th, 90th, and sometimes the 97th.
Let's do a quick refresher on percentiles. If a fetus is tracking at the 50th percentile for weight, what does that indicate?
It means that, based on the reference population for that specific gestational age, and often factoring in sex, 50% of healthy fetuses are larger than this measurement and 50% are smaller.
So the 50th percentile is the statistical mean, or average.
It is. A fetus tracking along the 50th percentile is considered to be meeting its potential in utero. It's the deviations, particularly below the 10th percentile or above the 90th, that trigger increased clinical vigilance and investigation.
We established that growth is a blend of intrinsic genetic versus extrinsic environmental factors. How does that play out in predicting fetal size?
It's a great question. The intrinsic factors, like the genetics inherited from the parents, their stature, their tendency toward early or late maturation, they set the potential range for the fetus.
The blueprint's maximum size.
Right. But the extrinsic environment, the intrauterine conditions, is the major determinant of whether that potential is actually reached. Maternal health is key here.
Things like maternal nutrition.
Nutrition, chronic diseases like kidney disease or uncontrolled diabetes, hypertension, social factors. They all influence placental function. And if the placental flow is compromised, the fetus simply cannot reach its genetic maximum, no matter how great its potential is.
So let's look at the serious end of that spectrum. Fetal growth restriction, or FGR. This is much more than just a small baby. It is a pathological state resulting from environmental or intrinsic limitations.
That's the critical distinction. FGR is defined as an estimated fetal weight, the EFW, that falls below the 10th percentile for gestational age.
And this used to be called IUGR.
Right, intrauterine growth restriction. These infants face significantly higher risks: increased perinatal mortality, stillbirth, and higher rates of neonatal complications like cerebral palsy, neurodevelopmental delays, and often lifelong metabolic issues.
Let's dedicate some time to the causes and contributing factors, the mechanisms behind FGR. What's going wrong?
The causes are generally tiered based on where the system failure is. First, you have maternal factors, which are on the supply side.
What does that include?
These are chronic factors that compromise maternal circulation or oxygenation. This includes heavy smoking, which causes vascular compromise and hypoxia, severe hypertension, which restricts blood flow to the placenta, or just poor nutrition.
So that's the supply line. What's next?
Next are placental factors, which is like the engine failing. The placenta is actually the most common primary cause.
And this involves?
Conditions that reduce the efficiency of nutrient transfer. Things like a placental infection, placental abruption, or most frequently, placental insufficiency, where the placenta simply fails to adequately perfuse and transfer nutrients and oxygen.
In the third category?
The third is fetal factors. These are intrinsic limitations, issues within the fetus itself. This could be a chromosomal abnormality, like a trisomy, which slows the innate rate of cellular proliferation, or a congenital infection, like cytomegalovirus, which damages rapidly dividing cells.
The source highlights the massive clinical utility of the head circumference to abdominal circumference ratio. That's figure 23.9. This ratio doesn't just measure size, it measures adaptation under duress. How does this ratio differentiate between the types of FGR?
It distinguishes the timing of the pathological insult. We typically see two main patterns.
Okay, what's the first?
The first is symmetrical FGR. This is usually from an early insult in gestation, first or early second trimester.
And what does that look like?
The HC, AC, and femur length are all equally small, so the HC to AC ratio remains relatively normal. It suggests a global growth failure affecting all tissues equally. Genetic factors or early severe infections often cause this.
And the second type?
The second is asymmetrical FGR. This is the more common form, and it usually results from placental insufficiency starting in the late second or third trimester. Here, the AC drops dramatically, while the HC is relatively preserved.
Leading to a high HC to AC ratio?
Exactly. And that high ratio is the key indicator of brain sparing. This is where it gets into the profound mechanisms of survival.
What exactly is the physiological trade-off the fetus is making here? What is brain sparing?
Brain sparing is an absolute survival reflex. When the fetus detects chronic hypoxia and a nutrient shortage, it fundamentally alters its circulation via the autonomic nervous system.
It reroutes the blood flow.
It triggers a massive redistribution of cardiac output. Blood flow is diverted away from tissues that can temporarily afford it, like the abdominal viscera, the kidneys, and the liver.
Which explains the small AC.
That's exactly why the AC is small, and why glycogen and fat storage are reduced. That blood is shunted preferentially toward the two most critical organs, the brain and the heart.
So the fetus sacrifices body mass and liver function to ensure neurodevelopment continues unhindered, maximizing its cognitive potential at the expense of its physical size. That is a heavy biological cost.
It is a critical trade-off. The immediate consequence is a baby born small, but with a relatively normal-sized head. But this metabolic reprogramming, the sacrifice of energy reserves, and the alteration of organ perfusion has long-term consequences.
Like what?
Research, like the Barker hypothesis, shows that infants who underwent severe brain sparing may have altered set points for blood pressure regulation and metabolism. This links FGR to an increased risk of hypertension, cardiovascular disease, and metabolic syndrome decades later. The trade-off made in utero for survival shapes the adult's health profile.
Given the urgency of FGR diagnosis, what clinical tools beyond just biometry are used to assess the current risk?
We use serial estimated fetal weight calculations, so we plot measurements over time to look at the trend, not just a single data point. If that trend line flattens or drops, intervention is often needed.
And there's another tool as well.
Most importantly, we use Doppler ultrasound to monitor the blood flow velocity in key vessels. We look at the umbilical artery to assess placental resistance, and crucially, the fetal middle cerebral artery, or MCA.
What does that tell you?
A reduction in the resistance in the MCA is the hallmark of brain sparing. It shows that blood is actively being shunted to the brain. Once these signs of compromise are identified, clinicians may opt for an early delivery to rescue the fetus from that toxic intrauterine environment.
Now, let's pivot to the opposite extreme. Macrosomia, the condition of excessive fetal growth. How is this clinically defined, and why does it carry its own distinct set of risks?
Macrosomia is defined in a couple of ways. It can be an absolute birth weight greater than 4,000 grams or sometimes 4,500 grams, regardless of gestational age. Or, more physiologically accurately, a weight plotting above the 90th percentile for that baby's specific gestational age.
In FGR, the primary cause is often placental failure and nutrient lack. In macrosomia, what drives this excessive, sometimes dangerous growth?
The primary mechanism is overwhelmingly nutrient excess, and it's driven by maternal metabolism. Macrosomia is strongly associated with poorly controlled maternal diabetes, either pre-gestational or gestational, and also maternal obesity.
So high maternal blood sugar leads to high fetal blood sugar.
Precisely. And the fetal response to that is to generate massive amounts of insulin.
Which leads to a state of fetal hyperinsulinemia.
Exactly. And in the developing fetus, insulin acts as a powerful anabolic growth factor, which is a bit different from its role in adults. This excess insulin stimulates the rapid uptake of glucose and the excessive deposition of fat and protein.
And this growth is disproportionate.
Very disproportionate. It often leads to a particularly large abdominal circumference and significant fat padding, especially around the shoulders and the trunk.
This disproportionate growth leads to immediate mechanical risks during birth. What are the key consequences?
The immediate risk is increased birth trauma, particularly shoulder dystocia. This is where the anterior shoulder gets stuck during a vaginal delivery because of that large shoulder circumference.
Which can cause serious injury.
It can lead to fractures or severe nerve damage like a brachial plexus injury. And postnatally, the neonate is at immediate risk of severe neonatal hypoglycemia.
Why is that?
Because their system is conditioned to high glucose loads and it continues to secrete high levels of insulin. But after birth, the placental glucose faucet is suddenly shut off, so their blood sugar plummets. They can also suffer respiratory problems and hyperbilirubinemia.
Beyond the immediate birth complications, these large infants also face the long-term risk of having their metabolic systems permanently reprogrammed by that high glucose, high insulin intrauterine environment.
That is the profound long-term consequence. The chronic hyperinsulinemia and high growth factor stimulation they experience in utero permanently program their fat cells, their appetite regulation, and their insulin sensitivity.
And that leads to?
These individuals are statistically at a far greater long-term risk for developing childhood obesity and type 2 diabetes themselves later in life. The metabolic damage begins well before birth.
And finally, let's revisit the sex difference in growth we noted. Does the typical size difference between males and females in adulthood start manifesting in utero?
Absolutely. The general trend is that male fetuses typically have a greater and more exaggerated growth velocity than females, especially in the third trimester. This leads to males being significantly larger at birth on average.
And in pathological conditions?
In conditions like maternal diabetes, the anabolic effects of insulin and growth factors are often more pronounced and accelerated in male fetuses, leading to an even greater difference in size compared to female fetuses under the same conditions. Sex is a physiological factor that must be accounted for on all growth charts.
We've tracked the growth trajectory from conception through the critical window to the moment of delivery. That instant, the transition from being fully supported to suddenly being independent, is arguably the most dramatic physiological shift any human will ever experience.
We call it the transition, and it's a non-negotiable systemic shift. The infant has to establish independent function across virtually every system that was previously managed by the placenta.
Let's start with the environmental hurdles they face.
The change is massive. First, thermal regulation. They move from the constant, humid 37 degrees Celsius environment of the womb to the outside world.
Which is much colder and drier.
Right. This requires the immediate establishment of independent thermoregulation, often relying on brown fat stores for non-shivering thermogenesis because their large surface area to volume ratio makes them prone to rapid heat loss.
And then there's food.
Yes, nutritional autonomy. The passive, continuous drip of nutrients from the placenta is replaced by intermittent feeding. This requires the establishment of active coordination, the suck-swallow-breathe reflex, as well as digestion and efficient absorption.
And they go from a sterile environment to one that's full of microbes.
Exactly. Microbial colonization. The sterile womb is immediately colonized by the mother's and the environment's flora. This colonization is crucial, initiating the essential establishment of a diverse gut microbial environment that influences everything from immune function to nutrient absorption.
But the single most dramatic physiological challenge must be the respiratory shift. Going from fluid-filled, high-resistance lungs to air-breathing organs is a massive architectural replumbing job.
It is the defining feature of the transition. The physical act requires clearing the fluid from the lungs, reducing pulmonary vascular resistance, which was very high in utero, and filling the millions of tiny air sacs, the alveoli, with air. And this entire process hinges on a specialized substance called surfactant.
Explain the role of surfactant here. Why is it so essential for this specific transition?
Surfactant is a complex lipoprotein produced by specialized cells in the lungs. Its purpose is to dramatically lower the surface tension within the alveoli.
So what does that do, practically?
Think of the alveoli like millions of tiny wet balloons. If they lack surfactant, the surface tension of the fluid lining them makes them prone to collapse completely upon exhalation. Surfactant acts like a detergent, keeping the alveoli patent or open, which prevents that collapse and allows for effective gas exchange.
And this is why preterm babies face such immediate, life-threatening risk.
Precisely. Surfactant production matures relatively late in gestation. If a baby is born significantly preterm, they often lack sufficient mature surfactant, and that leads to severe respiratory distress syndrome, or RDS.
And that causes.
The resulting alveolar collapse, the inability to exchange gases, and the resulting respiratory failure is a major cause of morbidity and mortality in premature infants. The shift from placenta-supported respiration to independent lung function requires this specific architectural element to be mature.
The timing of delivery, therefore, dictates the entire medical management and potential outcome. Let's formally establish the clinical boundaries using postmenstrual age.
The clinical definitions are very precise. Term delivery ranges from 37 weeks, which is called early term, up to 42 weeks, which is post-term. The optimal period for birth is considered 39 weeks and 0 days through 40 weeks and 6 days.
And preterm birth is anything before that.
Any birth occurring before 37 postmenstrual weeks is considered preterm.
And the gradient of risk is enormous, requiring further categorization of prematurity.
The categories dictate the level of required care and the prognosis. Extremely preterm is defined as being born at less than 28 weeks. These infants have exceptionally high mortality rates and require the most intensive, prolonged intervention. Their systems are profoundly immature.
And after that?
Very preterm is for births occurring between 28 and 32 weeks. Still high morbidity, but significantly improved survival rates compared to the extremely preterm group. Then you have moderate to late preterm, which is births between 32 and 37 weeks.
The sources specifically call out the late preterm period, from 34 to 37 weeks, as requiring special attention. Why is this group a focus area when they seem so close to full term?
This group represents a crucial clinical paradox. Historically, they were sometimes managed almost like full-term infants, but comprehensive research revealed that while their survival rate is excellent, their morbidity rate is surprisingly high.
They suffer from what are called late preterm complications.
Exactly. Things like subtle respiratory compromise, even without classic RDS, significant difficulties establishing feeding due to poor suck-swallow coordination, and dangerous instability in temperature regulation and glucose control. Their systems are not fully mature, and treating them as term infants leads to avoidable complications and higher risks of readmission.
So if we look at the architecture of a full-term neonate, we must constantly remind ourselves that this is not a miniature adult. The physical proportions and internal composition are unique.
Absolutely. We return to the concept of allometry. Figures 23.14 and 23.15 illustrate this perfectly. At birth, the head is disproportionately large, about 1/4 of the total body length, a proportion that will shrink dramatically as the trunk and limbs grow postnatally.
And the internal architecture is also radically different. Let's talk about the body composition of this newborn.
The chemical composition is heavily skewed towards hydration and fat stores that were accumulated late in gestation.
They have a high water content.
Very high. The neonate is highly aqueous, consisting of approximately 75 to 80% water, compared to closer to 60% in an adult. This higher water content impacts things like drug dosing and electrolyte balance.
And what about body fat?
Fetal fat accumulation is a massive driver of that late trimester weight gain. This fat isn't just a reserve, it's insulation. Body fat content can account for up to 46% of the weight difference observed between a preterm infant and a post-term infant.
Wow, almost half the weight gain.
It emphasizes its critical role in energy storage and, most importantly, early independent thermoregulation via that brown fat.
Given this unique composition and the rapid short-term velocity changes immediately after birth, standard adult measurement tools like body mass index or BMI are obviously useless.
And
How is growth accurately tracked in the first few months?
we rely on specialized charts. We use specific body mass index percentiles designed explicitly for full-term neonates and infants. These tools accurately track their unique growth trajectory.
And what do they help clinicians do?
Crucially, they help clinicians differentiate between infants who are genuinely pathologically small, or SGA, and require intervention, and those who are just constitutionally slender, but are growing perfectly normally along their genetically determined curve. This detailed tracking is essential because infant size is a profound indicator of overall health and metabolic status.
If a baby is born early, they begin with a massive size disadvantage. How long does this deficit persist, and what mechanisms are involved in the process of catch-up growth?
Catch-up growth is a compensatory mechanism where the infant attempts to bridge the developmental gap created by prematurity. We use the specialized WHO child growth standards, which are adapted for preterm infants, and they track growth from the due date, not the birth date.
And if we visualize figure 23.13, the preterm growth line starts far below the term infant curves for weight, length, and head circumference. What drives that accelerated growth velocity post-birth?
Once the infant is outside that adverse intrauterine environment and is receiving optimal nutrition, often through highly fortified breast milk or formula, the growth hormone IGF axis, which was suppressed by the placental insufficiency, rapidly reactivates.
So the body is essentially playing hyperspeed catch-up.
Exactly. This accelerated growth velocity is driven by the genetic mandate to reach the size potential it was denied in utero.
How successful is this process, and are there different outcomes based on the degree of prematurity?
Catch-up growth is often quite successful, especially for moderately or late preterm infants who are not severely growth restricted. Many preterm infants successfully achieve catch-up growth, meaning they reach the same weight, length, and head circumference percentiles as their term-born peers.
And by when does that usually happen?
By approximately 5 years of age postnatally. However, those born extremely small or those who suffered pathological fetal growth restriction in addition to prematurity may have long-term consequences. They may remain shorter for their age, suggesting that the early, severe nutritional deficits created permanent architectural limitations.
The initial chaotic sprint of the neonate gives way to years of systematic, though uneven, growth. We are now tracking growth over decades. What are the defined phases researchers use, and where are the major velocity changes?
Postnatal growth is divided into 3 major stages, defined by their unique hormonal and growth velocity profiles.
What are they?
First is infancy, which is from birth to 26 postmenstrual months. This is characterized by the fastest post-birth growth velocity. Second is childhood, from approximately 2 years up to the onset of puberty, so around 8 in girls, 10 in boys. This is a period of slow, steady growth. And third is adolescence, which is triggered by puberty and characterized by the final massive growth spurt.
Looking at the growth velocity curves in figure 23.8b, the rate of growth drops dramatically immediately after the first year.
Yes. The initial acceleration observed in the first 6 to 12 months is intense, but the velocity of weight and length gain then drops sharply. This slower, steady velocity is maintained throughout childhood.
Why is that?
It allows the body systems to mature functionally without the high metabolic demand required for that rapid growth.
We've established that the body is genetically mandated to find its natural size. This leads to the balancing acts we see in infancy: catch-up growth and catch-down growth.
These phenomena really illustrate the power of genetic set points. Catch-up growth, as we've discussed, is that rapid, intense growth phase seen when an infant born small for gestational age escapes the restricted intrauterine environment.
They're racing to catch up to their genetic curve.
Right. And catch-down growth is the opposite. It's a distinct slowing of the growth rate seen in infants who were born large for gestational age, maybe due to maternal overnutrition. They grew pathologically fast in utero. Once they're born, their growth velocity slows down to settle onto their genetically appropriate curve.
This suggests that once the external environmental insults are removed, genetics takes over almost immediately. How powerful is the genetic prediction of final height?
Extremely powerful. The source material emphasizes that by the age of 2, a child generally settles into the growth percentile channel that they will maintain throughout childhood and into adulthood. The parental size, their stature, is statistically the single strongest predictor of a child's height at age 2.
The long plateau of childhood is violently interrupted by the adolescent spurt, the final, most intense acceleration of linear growth. When do we define the onset of this period?
Puberty onset is defined by the appearance of secondary sexual characteristics, and it generally occurs around 10 years in girls and approximately 12 years in boys. This shift initiates the rapid change that culminates in the major growth spurt.
Figure 23.19 shows a clear difference in the timing and the magnitude of the peak height velocity, or PHV, between sexes. Why the difference?
The divergence is driven by the sex steroids, estrogens in girls and androgens in boys, which regulate the timing and intensity of the skeletal response.
So what does that look like for girls?
Girls hit their peak height velocity earlier, typically around 12 years of age. Their spurt is shorter and less intense, averaging a peak gain of about 10 centimeters per year. Their linear growth typically ceases around age 16.
And for boys?
Boys hit their PHV later, typically around 14 years of age. Their spurt is delayed but more intense, averaging a peak gain of around 13 centimeters per year. The longer duration and higher intensity of their spurt are major reasons why adult men achieve a greater final height.
What controls this massive final acceleration and, more critically, the cessation of growth? This is where the hormonal feedback loop is essential.
It is the combined action of 3 major hormonal signals. The spurt itself is caused by the rising secretion of growth hormone, or GH, and its systemic mediator, insulin-like growth factor 1, or IGF-1. That's what drives the proliferation of cartilage cells in the growth plates.
And the sex steroids?
Concurrently, the rising levels of sex steroids, testosterone in boys, estrogen in girls, amplify this growth, leading to that rapid increase in height velocity.
But the paradox is that these same-sex steroids, which accelerate growth, are also ultimately responsible for stopping it. How does that mechanism work?
This is a really nuanced mechanical point. Sex steroids, particularly estrogens, even in males where testosterone is converted into estrogen, have a dual effect on the epiphyseal plates or the growth plates.
They do 2 things at once.
They stimulate the proliferation of cartilage cells, which makes the bone grow longer. But they accelerate bone maturation and ossification even faster than they accelerate the growth itself.
So they press the gas pedal and the brake pedal. But the brake pedal is slightly more sensitive to the hormone concentration.
Precisely. High circulating levels of estrogen eventually lead to the definitive closure of the epiphyseal plates. The cartilage is converted entirely to bone, fusing the end of the bone to the shaft.
And once that fusion occurs,
Once that closure occurs, typically around 18 years of age, linear growth ceases forever, marking the final stage of physical maturation.
the discussion of proportions in the neonate led us to the core concept that the body does not grow uniformly. It is not a scalable model. Allometric growth dictates that different organs and body parts grow at vastly different rates and stop at different times.
Yeah.
How does this disproportionate growth fundamentally shape the human form?
Allometric growth, the differential growth rate of parts relative to the whole, is a reflection of evolutionary and developmental priorities. It ensures that the systems necessary for survival and cognition mature first, followed by the systems necessary for mobility, reproduction, and defense.
We see this most dramatically in the shifting proportions of the head.
Visually, it's stark. If you look at figure 23.21, the head, as we mentioned, is about 1/4 of the total body length at birth. It needs to house that large, rapidly developing brain.
And then it slows down.
Post-birth, the growth of the skull slows considerably, while the growth of the trunk and the limbs accelerates dramatically, especially during adolescence. By adulthood, the head constitutes only about 1/8 of the total body length. And this shift isn't just cosmetic, it changes the center of gravity, facilitating the transition from crawling to bipedal locomotion.
Figure 23.22, the classic Scammons curves, visually confirms that the body is not operating on a single clock. It shows 4 profoundly different growth trajectories running concurrently in the same organism. Let's break down the timing and implications of these 4 distinct patterns of organ and tissue growth.
Scammons curves are a critical piece of anatomical understanding. They illustrate this specialized developmental timing. The first is the neural brain and head curve.
And what does that show?
This curve reflects the absolute prioritization of the central nervous system. It exhibits the most rapid early postnatal growth, reaching close to 100% of its final adult size by about age 7 or 8.
That early completion implies that the critical window for establishing cognitive architecture closes relatively early.
It does. It underscores the intense plasticity and sensitivity of the brain in early childhood. By the time a child enters second or third grade, their brain size is essentially that of an adult, emphasizing that intervening environmental factors like nutrition, education, and stimulus have the most profound structural effects in those early years.
Okay, what's the second curve?
The second is the lymphoid tissue curve, which covers the thymus, lymph nodes, and spleen. This pattern is the most counterintuitive.
Why is that?
It exhibits explosive growth in mid-childhood, actually peaking at nearly 200% of adult size around age 8 to 10.
Why would the immune system double its required adult size right before puberty? What is the function of this massive temporary overgrowth?
This temporary overgrowth reflects a massive investment in immunological infrastructure. It happens during a period of intense social interaction when children are encountering and building immunity against a wide variety of childhood pathogens. The body is maximizing its surveillance capacity.
And then it shrinks.
The dramatic decline of this tissue during adolescence is largely attributed to the surge of sex steroids, which have a profound suppressive and involutional effect on lymphoid tissues, particularly the thymus.
So the third curve is the one we think of as normal growth.
Yes, the general body growth curve. This covers the skeleton, muscle, respiratory, and digestive organs. This is the typical S-curve we associate with human growth. It slows after infancy, maintains a plateau during childhood, and then has that steep acceleration during the adolescent spurt.
And the fourth and final curve?
The reproductive organs curve. This is the most delayed. It's an almost flat line curve throughout infancy and childhood, showing minimal growth. Then, at the onset of puberty, around age 12, it displays an acute, almost exponential acceleration, driven entirely by the rising levels of sex steroids.
It is genuinely remarkable that these four profoundly different system clocks are running in parallel, demonstrating that human development is a highly coordinated but non-uniform process.
And this dynamic coordination brings us back to the core interplay of genetics and environment. We have to re-emphasize that while genetics set the potential range for all these curves, the extrinsic factors heavily influence the speed and magnitude of the growth realized across all systems.
What impact does this environmental influence have on how we, as a society, monitor growth? We hear constantly about updating growth charts.
Growth charts are statistical averages, and they're only valid if the underlying population is healthy. Since environmental factors, nutrition, sanitation, access to healthcare change over time, the average healthy size changes. This is the secular trend in growth. Using outdated historical standards from, say, 50 years ago risks misclassifying a child who is currently at a healthy percentile as being excessively large.
So the charts must be periodically revised.
They have to be, to reflect the current healthy growth of well-nourished populations.
And finally, let's synthesize the chemical messenger that regulates nearly all this growth, from the Carnegie stages through epiphyseal closure.
That is the growth hormone insulin-like growth factor axis, or the GH-IGF axis. This axis is the central conductor. It's involved in regulating cellular proliferation and differentiation even before birth. It drives the general growth curve, modulates the reproductive curve, and is critical for bone maintenance long after growth stops.
So any disruption to that axis has huge consequences.
Immediate visible consequences on height and body structure, and long-term implications for metabolic and cardiovascular health throughout life.
The level of complexity is overwhelming yet perfectly orchestrated.
It really is.
We have completed the journey from the microscopic precision of the Carnegie stages, where the fundamental architecture is laid down in 56 days, through the detailed biometry used to track mass accumulation, and finally through the dramatically different clock speeds of the lymphoid, neural, and reproductive systems in childhood and adolescence. The sheer coordination of these separate system timelines is, frankly, astonishing.
The central unifying takeaway for you, the learner, is that growth tracking, whether it's prenatal Doppler, postnatal BMI, or height charts, is not a passive measurement of size. It is an active diagnostic tool for timing.
Timing is everything in developmental biology.
Absolutely. When a fetus or a child deviates significantly from the statistical norm, from that 50th percentile, whether it's through FGR or macrosomia. That deviation is the body broadcasting a metabolic distress signal. It's indicating that the underlying developmental clock is off.
And that requires immediate clinical investigation.
It does, because growth is the most reliable barometer of an organism's health, its genetic potential, and its environmental reality. We covered how the body makes survival trade-offs in utero, such as that brain-sparing response during FGR. The final provocative thought for you to consider, based deeply on the research, is this. The source material highlights that the subtle architectural decisions made during gestation, for example, the precise ratio of placental mass to birth weight or the exact allocation of nutrients, they don't disappear at birth.
They echo throughout life.
They absolutely do. These subtle ratios and developmental trajectories established in utero have been definitively shown to affect long-term cardiovascular risk, obesity predisposition, and metabolic outcomes decades later. So think about how these faint echoes of your prenatal environment, these subtle architectural decisions, influence your health profile for your entire lifespan, long after the growth plates have closed and the adolescent spurt is a distant memory.
An absolutely dense and deeply integrated deep dive today. Thank you for mapping this incredible, essential biological journey with us. We'll see you next time on The Deep Dive.